Thank you, Martha, for your introduction. And dear colleagues, again, it's a great pleasure here to share with you the important topic here of in treatment of atrial fibrillation in terms of heart failure. So we all know the new guidelines for disease management of atrial fibrillation of the European Society of Cardiology updated this year. And we move from the ABC scheme to the so-called CARE. We look at the care from the patients. So when you regard the heart failure and care, you have to do, we have learned it here from Professor Wing, the diuretics for congestion, appropriate, have ref medical therapy, SGLT2 inhibitors, and oral anticoagulation, and then thinking about rate or rhythm control, and then re-evaluation and dynamic reassessment. Well, this is my agenda. First, I want to look at the patients with reserve or mild reduced ejection fraction. And here, concerning the HFpEF patients, I've seen some interesting publications shown that about 50% of heart failure patients suffer from heart failure with preserved ejection fraction, and otherwise the AF prevalence in the patients heart failure with preserved ejection fractions ranges from 25% to 60%. So that there is the great coincidence and of HFpEF patients and atrial fibrillation. So that is pathophysiology of the HFpEF and atrial fibrillation. And so you see that when you have HFpEF, you have a 6.8 risk to develop atrial fibrillation. And when the atrial fibrillation leads to the 2.3 for risk to develop HFpEF. And there's here an interesting small study concerning patients with HFpEF and atrial fibrillation. It's a so-called CABA-HFpEF study, and this study have investigated the functional parameters in HFpEF patients with atrial fibrillation, and the patients were ablated the primary endpoint with the change in wedge pressure. And interesting is here that post-ablation, about half of the patients have no more HFpEF criteria, comparing to medical therapy. And that leads to the study that we are that is going on, and this is the so-called CABA-HFpEF DCHK27 study. It will include more than 1,500 patients over 60 sites, recruitment over 36 months. And the primary composite endpoint of the study is cardiovascular death, stroke, and total of unplanned CV hospitalization for heart failure or acute coronary syndrome. And we are very excited to expect the results. So the next group is the patients with reduced ejection fraction. And so here I want to show you first an interesting slide about effect of arrhythmias on LV function. And you know, when you look at left bundle branch block or atrial pacing and ventricular pacing, all that effect of arrhythmias reduces the left ventricular ejection fraction. And also the atrial fibrillation leads to the 40% of reduction of LVEF. And you see that is so-called the arrhythmias can reduce LV function and can lead to heart failure. And first, I want to show you one slide. This is the email. Okay. Yeah. First, I want to show you the case report. There's a rather 83 years patient who has persistent atrial fibrillation since 3 years, a large left atrium, diabetes, hypertension, coronary artery disease, and a really markedly reduced ejection fraction from 25%. New York Heart Association 2 to 3, and has a mitral valve clipping in 2020 and 1 chamber ICD implanted. So really sick and old patient. And when you want to, when you have such a patient, you have so-called clinical scores that can help you to identify his risk or his success rate from therapy of atrial fibrillation. And there are some kind of clinical scores published here. You see here the most common, this is the CHA2DS2-VASc score, or here from one of my friends in Leipzig, the so-called Dr. Flash score. And this score included here several criteria that are well known, like age or here body mass index, heart failure, hypertension, LV ejection fraction, and so on. And so I have take one of this score here for an example. That is a Dr. Flash score from published from the group in Leipzig in former times. And when you do the risk evaluation with this score, you have here in this patient's diabetes, persistent form of atrial fibrillation, a markedly dilated left atrium, age more than 65 years, and hypertension. And in this score, you have 5-point risk score of this patient have so called a very poor prognosis. When you put on this score, and the patients we have ablated with the new form, the pulse field ablation is done, the voltage map of this patient. You see here, after pulmonary vein isolation here, and the left atrium was rather very healthy. You know, this is very surprising. You have this score, you have the markedly large left atrium, and you have an electrically healthy left atrium. So this is very surprising, and you see that you can not always compare and take the score for the prognosis. And so in the next video, I want to show you one live case here of such a pulse field ablation at our institution. Now advance into the left superior pulmonary vein, and now you see here the yellow tracing. That's important. Here above, there's a yellow tracing. These are the pulmonary veins, and so you put the electrical shock of the pulse field, and after a few seconds, the big electrograms were disappearing. So this is a very fast ablation procedure for these patients. Now, it's very interesting, and so this ablation method is very fast and with less complications, and so we can also use them in patients who are very old or very sick. So next slide, please. Next slide. Well, you all know the so-called CASTLE-F study, which investigated the catheter ablation patients with reduced ejection fraction with heart failure. Next slide, please. And you see, you can know the results. Next slide, please. You see the results that the ablation group is better than medical therapy in the so-called CASTLE-F study published in New England Journal of Medicine in 2018. So when you look at the risk factors for patients who were in hospital, so you have to ask, is it still safe to perform an ablation? And here's a very interesting study from the Shang and Jack that investigate the risk factors for early mortality post-AF ablation. And he has found out that there are 3 criteria which determine the risk of early mortality. So the first is, of course, the procedural complications as pericardial effusion and so on. The second one is the congestive heart failure. It's a very important criteria for the early mortality post-ablation. And the third one is also very logical, so low ablation hospital volume that determine the risk of ablation. And the trend is that the risk is rising here because of the complex patients. And so we're looking at the congestive heart failure as a rather risk factor of these patients. And that leads me to the so-called Castle HTX study from Zones and from the Philip Sommer. And this is a single center open label investigator initiated studies, randomized nearly 200 patients, one-to-one ablation versus medical therapy. And the aim is to show the superiority of ablation versus medical therapy in terms of a composite end point of death from any cause, LVAD, implantation or urgent heart transplantation, and death from any cause. And the duration of follow-up was approximately 3 years. And so the patient characteristic, I want to skip that in terms of time. And these are the result of the study published this year in New England Journal of Medicine. You see here that the ablation group has done much better. There's a high significantly effect of catheter ablation, the atrial fibrillation, considering all the primary endpoint and also the secondary endpoints. Here, primary endpoint on the 8 to 29 cases with a high significant DP value, and also death from any cause, and also high significant from implantation of LVAD. And this year, the ESC in London, they have presented, the group have presented the 2 years follow-up of the Castle HTX trial. I have shown the persisting effect in the ablation group. It's also high significantly superiority of the ablation group comparing to the medical therapy group, and let's reach through the markedly reduction of the mean atrial fibrillation burden in the ablation group. So we think that there's a high the burden is very important for the prognosis. This is a very high effective and high successful study, but always there's also critics in the study. Here is one commentary here, actually in the JACC paper. Can we trust the Castle HTX trial? The Castle HTX trial have also some critical points, that this is a small study, it's a one single center, and also that the patients were not blinded. The patient was not blinded, and so there's some bias that can can affect the results of this study. But however, the paradigm shift is completed now concerning patients with heart failure. See here from the ACC 2023 guidelines, 1A indication in appropriate patients with the F and HFrEF who are on optimal medical therapy and with reasonable expectation of procedural benefit. Catheter ablation is beneficial to improve symptoms, quality of life, ventricular function, cardiovascular outcome. From the ACC and also the ESC have the guidelines here with the class 1 indication for patients with AF and HFrEF, and also patients here is recommended with high probability of tachycardia-induced cardiomyopathy, and also in patients without tachycardia-induced cardiomyopathy, also with the class 2A recommendation. So in the last slides, I need 2 more minutes. I want to show you that now we have the high evidence for catheter ablation, and we have to do the ablation early. Here's a nice study from Sakamoto who shows that the early ablation affects the mortality in heart failure patients. You see here the all-cause mortality is rather low in patients with early catheter ablation, concerning to control patients. And last but not least, you don't forget the AV node ablation with implantation of a pacemaker before. The study here from Brignoli shows that the patients with atrial fibrillation and heart failure, when you do this AV node ablation with implanted device before, like a pacemaker or a CRT, comparing with pharmacological therapy, we have a rather better outcome in patients concerning heart failure, hospitalization, worsening of heart failure symptoms, and also all-cause mortality. So when you are not able to achieve the sinus rhythm and the patient is also symptomatic with tachycardia, atrial fibrillation, the AV node ablation is a very potential therapy. So that I will to skip this in concern of times. Or maybe I can say one aspect of these slides. When you have patients who are below, it's very interesting, below than 50 years old, and you have atrial fibrillation, in some percent of this patients, the atrial fibrillation is the first manifestation form of such a kind of cardiomyopathy. And you see here some genetic defects of cardiomyopathy of Lamin or KCNQ1, and some of the patients with early onset of atrial fibrillation, that is the first onset of such kind of cardiomyopathy. So ladies and gentlemen, dear colleagues, I want to summarize my talk for today. There's no really data in HFpEF patients, but the pathophysiological benefit is expectable. We expect the data from the HFpEF study. AF ablation is in patients with severe systolic heart failure can reduce mortality. The catheter ablation improves LV function, reduces AF burden, AF regression in end-stage heart failure. An early intervention is very important. Risk factor management, rhythm control, reduction of AF burden, and concerning AF in the young below than 50 years, there's a possible first manifestation of genetic cardiomyopathy. Thank you for your attention.